So thank you so much, organizers, for giving this opportunity to me. I rarely see a hall full as so many people that I see today. So I think post-COVID, we tend to get nervous to see so many people. So this is an ASCO paper which was presented by optimization of treatment options in EGFR mutant unresectable lung cancer. We've come a long journey from 1980, from RTOG 7301 trial where we were only irradiating these patients, to sequential chemoradiotherapy, to this current standard of care from Pacific trial of Druva plus Druva after CTRT. And a lot has changed in the EGFR space where you have the new ADORA trial, adjuvant TKI. So things in EGFR space we are still trying to understand. So what is the ideal optimum treatment for stage 3 post CTRT or post RT? Whether they should go for Druva, whether they should go for TKI is still a question that needs to be answered. I'll take you to a study which was published that whether Durvalumab for a stage 3 EGFR mutant NSCLC after definitive chemoradiotherapy is the right answer or not. And this was through Stanford University School of Medicine in California. They concluded that patients who are EGFR mutant, they had very high adverse events when they were given Durvalumab consolidation. And when osimertinib was given, then they were susceptible to very, very high. So this was not the right answer. So what the Chinese investigators did, they took up all the trials available in the records for stage 3 NSCLC, whether they had received CTRT or sequential CT followed by RT, followed by TKI, and they started collecting this data for analysis. So in total, initially 957 studies were eligible, excluding, and they came to 17 studies. The 5 treatment measures were concurrent CTRT followed by Druva, TKI monotherapy in stage 3, radiotherapy followed by TKI, and CRT followed by TKI. The primary endpoint was PFS OS and measure the adverse events. The staggering number of 3,291 patients were available for analysis. And based on the Bayesian network meta-analysis, this is what they could come up with. This looks complicated, but I'll take you to the points. What their finding was that overall response rates in RT followed by TKI were significantly higher than the chemoradiotherapy arm. PFS with TKI containing measures including TKI, RT followed by TKI or chemoradiotherapy followed by TKI were significantly longer than concurrent chemoradiotherapy alone. PFS with both RT and TKI and chemoradiotherapy and TKI were higher than CRT plus Druva. So I think that is something which the study was also pointing that in mutant, maybe immunotherapy is not the right answer. No significant difference in OS among patients among all the treatment options. TKI alone had a significantly shorter PFS. So local RT was a must in stage 3 non-resectable lung cancers, and RT plus followed by TKI ranked the first in terms of overall survival benefit. When we look at the side effects, pneumonitis, post-radiation pneumonitis was the most common when TKI was used along with RT or chemoradiotherapy. Severe neutropenia was the most common side effect. This was also documented in one of the phase 2 study by Japan where they used TKI plus radiotherapy concurrently. The neutropenia was very high. Serious adverse events in TKI with or after Durvalumab administration is worth noticing, and that's one study that I've shown you from the California group. So in conclusion, RT and TKI for stage 3 EGFR mutant NSCLC are important. This gives more strength to ADORA trial that there is a role of adjuvant TKI in mutant lung cancers in non-metastatic settings. RT plus TKI may be the optimal treatment regimen based on the current data. Due to lack of efficacy, chemoradiotherapy plus TKI needs to be evaluated. Maybe we are over-treating it and we are looking at more side effect profile. I still am, holding my hands down for role of immunotherapy in EGFR mutant lung cancers. We know that from metastatic settings. Again, this data is a good analysis that, Durvalumab in EGFR mutant stage 3 lung cancers is the question mark. Thank you.